Good. So what I want to know is what, if you could take one thing home with you today from this talk, this work that we're going to do today, what would it be?
Parkinson's and constipation. Parkinson's and constipation.
Parkinson's and constipation.
Oh, I just feel like anything. I just want to learn it all.
Okay.
Yeah, whatever you have to
All right.
learn.
Strategies for bloating.
Strategies for bloating.
Yeah, how to regulate, get into like a regular bowel movement system.
Right.
Prevent bloating.
Right.
Yeah.
Right. Right. Great. Great. Anything stand out to you? Lauren?
Oh, just kind of the same thing that
Okay.
we both kind of mentioned here.
Like better supporting our clients with IBS because that's just a
Oh, yeah.
diagnosis.
Yeah,
It's
we're
like-
going to talk about IBS. If you can't talk about swelling, bloating, distension without talking about IBS. They just don't exist away from each other. Anything else?
I think, oh, sorry, go ahead.
Go ahead.
I am very interested in hypermobile patients. I find a lot of hypermobile patients. I find a lot of challenges, even when the pelvic floor coordination and tone appears to be relatively good with that population.
Yeah, we'll talk about that for sure too.
I really want to increase my understanding of IBS and connection to pelvic health, which I know is there, but I think the second piece of that is the vocabulary and how to help my clients understand that.
Okay. Perfect. Perfect. Anything else?
Nervous system layer. Yeah. Little nervous system layer in there.
Oh, we're going to layer that nervous system in. That's all we do. That's all we do. I'm with you.
What about our role with Dietary, you know, where that line where we are in that educating the patient, how that is affecting the bowel?
Okay. Good.
Yeah, I was gonna say like patient education tasks, but they most likely already heard from the numerous doctors that they went to.
Okay. If you're going to sit in the back, you have to talk loud because I like listen to way too much rock and roll music. Really loud. I was the one who sat next to the speakers at the concerts, so they told me it would happen, and it did. It did.
I feel like I've had a cluster of patients that I don't know how to handle when they have a flare.
Okay.
During the management, it's okay, but the flares, I just feel.
Right. Right.
How to better support the recognition of the mental health and IBS piece?
Okay. Yeah. Wonderful. Cool. So you came to the right talk. Hopefully. All right. There's the objectives. I don't need to read those out loud, do I? All right. Good. So one of the things we wanted to know in the very beginning, I'll just give you a little historical piece. I'm not going to spend a lot of time with this. You're going to have the slides. You can read the stuff. All this does is says that there's a lot of people who have what they call functional gastrointestinal disorders. Right? Well, I never understood why they call them functional.
Because it's non-functional.
Organic or non-organic, right? And this is organic, as we're going to talk about. Before they didn't know what to do with them because they didn't have something like inflammatory bowel disease or colitis or some injury or something going on. They just grouped them all into this other group, and then they cast a group called the Rome group, R-O-M-E, Rome 4 is the newest one, and that's when they started doing all the research. So we've gone from Rome 1 to Rome 4, and if you haven't been on the Rome website lately, you should. There's some really, really, really good articles about what's going on. They are now recognizing permeability problems in the GI lining. They used to laugh at us. They laughed at functional medicine doctors. They laughed. They said there's no such thing as leaky gut. Well, now there is, all of a sudden. And now they're using that to explain T cell, mast cell, histamine receptor activation. Because things are getting into the bloodstream that don't belong there. How do we get a breakdown of the permeability of the lining? Through stress, cortisol, adverse events, inability to regulate, life's changes, autoimmunities, Whatever switches on autoimmunities, I tell you, is probably going to switch on the leaky, the cell, this, you know, the cell kind of like non-closure piece that's going on, so things are sliding through. So we have a lot of stuff that should stay in the lumen. It gets in the bloodstream. Gets in the bloodstream, and we have problems. And when it lasts long enough, we don't feel good, and we start having other things, which is what we'll talk about, the bloating and irritable bowel syndrome. So when you look at the statistics, 60 to 90% reported bloating as the most bothersome symptom. So when people have IBS, they have visceral hypersensitivity, right? So the basic definition of that is they have an allodynic response to normal stretch of the lumen in the GI system. Okay, we all have gas. We all have foods that draw water in rapidly. We all bulk up with fiber. We all do these things. But for these people, it doesn't feel good. All right, the rest of us are like, oh, I've got some gas. Better move around and do something to get rid of it, right? It's normal. For these people, it's not. It feels bad. Women greater than men, especially perimenopause. So I will jump up and down now and make a little plea that as we move forward together in the pelvic health world, together as a team, that we start paying more attention to perimenopause and what I like to call the pinnacle of life. Because menopause is associated with such negative connotations out there. My market research has been very clear. So I like to call it life's pinnacle. That there's a lot we can do here, but they run into a lot of problems in this area too. Why? Because we're starting to learn to live without estrogen. And guess what? We did it before. We can do it again. We did. We lived for like a bunch of years without it. We don't have to have it. And women live decades at their life's pinnacle. So we need to be paying more attention to this. The one thing I like the best about this article, and the reason I'm spending so much time here, is that these are the things associated not only with bloating and distension, but with IBS, okay? And chronic constipation, which, by the way, is IBS constipation. Rome had to separate it out because that's what you do with research, that anybody who has chronic constipation has IBS, right? They're uncomfortable. They don't feel good. They don't like it, and they become hypervigilant about going to the bathroom. And so much so, many of them turn it into a ritual. Hypervigilance is a big thing. People worry about if they're going to have bloating and distension after they eat. Why do I feel so bad? How come every day at 4 o'clock I start to feel like, ew, and my clothes, and I have to unbutton my pants, and then all of this starts to happen. Why does it happen every day at this time? How come I wake up and I feel better? It's probably you mitigated some of that nonsense during your sleep, right? But here's the big thing, and this is going to fall right into our world, and I get emails on this constantly. Is this in our wheelhouse? 100%. I have never seen a client with IBS presentation that could not trace it back to an adverse event. Okay? Adverse events come in all shapes, forms, and sizes, as we know. They can be quite traumatic. They can be as simple as moving to a new town. Doesn't matter, but as soon as you ask the questions, when did this start? Right? What was going on in your life at that time? What happened before this? And they'll give you some kind of blow-off answer like, oh, that's not why I have this. And it's like, well, what happened? They tell you the story. And this started right after that? Yeah. Oh my God. Is that because of this? Right? And it's like, well, it's not helping because your system, learned to live with all of that and hasn't got to figure out a way for us to get rid of that. So here's the number of people with bloating in the United States. 1 in 7 out of an 89,000 kind of cohort that they looked at. So what does that mean? Again, more women associated with constipation, also with their inflammatory bowel disease. That makes sense though, right? And then 58% never sought care. I don't even think I need to say anything more, do I? This crowd gets it. This crowd gets it. Usually all of this stuff that I do too is to try to convince my orthopedic counterparts why they need to understand this. When they want to tell me, I don't need to know this stuff. It's like, yes, you do. Because we know from another study that a lot of that, at least 80 to 87% of women with chronic low back pain also have GI dysfunction, right? All right, so this particular study was an attempt to start to kind of build a medical algorithm. And what I've done here is I've circled the things in red where we can come in to this space, right, where we should be invited in. There's other places, of course, to be invited in, but these are two of the traditional ways that we can be invited in. So they look at, let's give them an antispasmodic if they've got IBS and abdominal bloating and distension, right? Take some peppermint oil. Well, if you have GERD, peppermint oil isn't going to work very well. So maybe ginger instead. The Dietary, the FODMAP diet, a lot has been written and said about the FODMAP diet. It is an elimination diet. It is one that has an 80% rate of success if it's done correctly. This is a very, very, very hard thing to do correctly without support, because it takes away, in the beginning, everything that people love and enjoy, even if it makes them sick. They're kind of willing, anybody can do anything for 2 weeks, right? We can all do anything for 2 weeks. But if I have to do this for 6 months, no way. No way. So they're excited in the beginning and then it quickly falls because it's hard to do. So they need the right kind of support and things like that in order to do this. But the biggest things are going to be dairy and sometimes gluten, like a lot of fatty foods. But I'll tell you the lowest hanging thing out there, sugar. If your client wants to do one thing dietary-wise to change their symptoms, and they will all ask about gluten and dairy. That's getting all the highlights, right? It's because we've got glycophosates in the wheat, in the agriculture, and the cows are eating it. But the one thing that they can do is start to back away and eliminate sugar. Why do they have such a sugar hang-up? Because there's a chronic stress thing going on in there. And we can't live in cortisol without sugar. You can't do it. And they'll tell you their willpower is terrible, and that they just can't, I don't know why, I do really good for a couple of days and then I just go crazy. It's like, because it has nothing to do with the part of your brain that gives you willpower. It has nothing to do with that. It's all run by the sympathetic mediated system. And it does that on purpose because that system's pure thing for us is individual survival. It's to keep us alive. And if we have to have sugar to get glucose to our brain so we can keep going, then it is going to find a way to make us get the sugar. And not only is it going to do it up there, but it's going to do it through the gut. So we're going to grow bacteria that screams for sugar because we're eating the sugar. And the bacteria is having a party going, give me sugar, lots and lots of sugar, let's go, baby. We got work to do today, better get me some sugar. Don't forget the caffeine, right? Don't forget the caffeine, we need that too. Let's put the caffeine and the sugar together. Even better. Here's a Red Bull, right? And then once we do that, and one of the things we know when we disrupt our sleep is that it's harder to control our food. Why? Because we need to wake up. And so we will grab more things that are sugar-based to keep us going through the day. So they're running on a factory of cortisol instead of a good factory of nutrition where, that whole listen to your body thing is so important here, that here is not going to be something we're going to start with. because they can't hear it. All they hear is sugar, right? And all they hear is I feel bad. And then I eat because I have to, and then I feel bad. And then I don't sleep. And then I do sleep and I feel good, but then I eat again and then I feel bad. That's what they can hear. So we got to help them bring the noise level down.
Susan, does it depend on the sugar, because there's fructose and fruits and some vegetables and stuff, so is that important, or is it just the refined sugar?
The refined sugar is the most important, right? I think everybody can agree with that. And I love the honey and the maple syrup and the monk fruit and all of the things, but at the end of the day, it's still sugar, right? It may be that you can replace white sugar with monk fruit, but you have to still remember how much sugar, how many times are you putting the sugar into the coffee? You know, people do things automatically, right? And this crowd knows this better than anybody. It's their job to break the habits and to help people establish new and different ones. And all of these automatic things, we do it mindlessly. Can you remember brushing your teeth last night? You did it, but did you really stay in the moment? Did you feel the water and the taste of the toothpaste and the vibration of your electric toothbrush? Did you feel it touching your gums? Did you feel everything about it? Right? No. So what we want them to do is be aware of every time you're reaching for sugar, perhaps. We get into that. So the other thing that they do is they look for SIBO here. And, SIBO is nothing but undigested food in your small intestine. So we have to consider the whole system here with this. We can't just look straight at the belly, because the belly is the victim of other things going on. That means if we have undigested food in our stomach, then we're not digesting our food in our stomach. In our small intestine, we're not digesting the food in our stomach where it should be digested. And that is protein. And we have acid pumps and pepsin in our stomach for a reason. And that's to pulverize that stuff so that it goes into the small intestine in a very pulverized state so that more things can be removed from it into the system. Okay, if we're not getting that done, we're on proton pump inhibitors every night to lay down and go to bed because we have GERD on top of the swelling, then we're continuing to have undigested food slip through. So they try to treat it. Here's a problem though, when we start treating it with antibiotics, people will do it, they'll feel better, they don't change what they're doing, and it comes back. They'll do it, they feel better, then they don't change what they're doing, and it comes back. How many times can you take antibiotics before you think your gut lining is going to tear up? Usually the recommendation is to do a month of probiotics after a round of antibiotics, just to kind of help. Do a little restoration, right? Because antibiotics are pretty widespread. They're going to kill just about everything in their track if they can do it.
Is that true for babies that are on recurrent antibiotics for ear infections?
Could be. Yeah, I'm not a big peds person,
Oh, yeah.
so peds questions are deferred to the peds people. But they oftentimes what they're doing now, what I understand, is that they're doing probiotics with babies, especially the ones that are having a lot of trouble. They're putting them on some probiotic as a beginning thing versus trying to do other things. And then, of course, what is mom drinking and eating?
You had said that if the acid in the stomach is not breaking down food, you said that's a protein thing. What do you mean by that?
Pepsin breaks down protein. So pepsin is the enzyme in the stomach, great question, that breaks down protein. And it is activated at a pH of 2. So it's got to have a high acidity area for that to occur. Because the acid activates the pepsin breaks down the proteins, and then the stomach says we're done, it opens up, and now things flood into the duodenum. And that's when we start in the duodenum, is where we start getting all the other things that are coming in. Right? We get some bile, and we get pancreatic juices, and we get other enzymes and all the other things to take care of the other stuff. So the protein needs to be digested in the stomach. So, and that's why we have those two sphincters that close off, so that we can have that highly acidic churning deal going on in order for that to work. And then the final thing they look at, well, okay, so down here, they're still not better, so we're going to send them to a neurogastroenterology center. We're going to look at electromyography. But before we do that, let's, you should consider taking an SSRI, right? That's what we'll give you. It'll make you feel better. Don't worry so much. What's the problem with SSRIs if we've got constipation? They make you more constipated. It's like, wait, don't treat constipation with a constipation-making drug. Let's find a better way. There's better ways, and they're learning. They're looking at that. They're beginning to realize that, okay, this is probably not the best way to go. So, but you're going to find your people are on this. They're going to be on antibiotics. They're going to be taking, these other things. They're going to be on SSRIs. And I never suggest that anybody gets off of them. It's like, let's pay closer attention to what you're eating and what you're doing, because we want to optimize your system, because these things can make you more sluggish, right? And some people will say, oh, I need this. It makes me feel better in my head, but I can't poop when I do it. So now they're taking other things to help them poop. And it's like, let's see what we can do to kind of write the whole system together. Where we have the circles here are important because the first thing they talk about, to treat accordingly over here, they say, no, they don't have any of this stuff. Psychological disorders, maybe they're naming that wrong. Maybe they're not considering mental health, like all of it. They're just thinking of the big things. Anyway, so no, first thing, reassure them, and then recommend some diaphragm breathing. Okay, has anybody ever learned how to breathe first of all, do we need to learn how to breathe? No, we can breathe. But do we need to maybe change our breathing for our purpose, make it relevant? Yes. Do they teach that at that level? No. This is where we should be getting referrals. Here at the top. Not down here at the bottom when they finally give up, throw the towel in and say, go see a pelvic health person and get some biofeedback. Yeah.
And you'll probably speak to this, but it seems to me that this whole flow chart is backwards.
Of course it is.
So because based on what you were just talking about, if so much of this is mediated by trauma and mental health, then I would also think that psychological therapy, hypnotherapy, all those things would be farther up the intervention list, even though we're saying they don't have a psychological disorder, but with how connected we know this is to mental health, even if they don't have a diagnosed psychological
And it's more chronic.
Right.
Because the more chronic it is, the more it's been going on.
Yeah.
And if it just happened, for the last 3 months, they may not need an SSRI to get out of it. Right? But if it's been going on a long time, they're going to definitely need support, and sooner, not later.
Right.
100%. So that's why I put this up here, because, we have to kind of know where we are. All right. So, same thing. This one decided to let's look at a practical approach to this. And so, 60 to 90% of IBS have bloating and distension. I haven't really met anybody with IBS that doesn't have some form of this, but I've never met anybody with bloating and distension that doesn't have IBS. Right? So make no mistake about it. You're working with somebody with IBS that has this other symptom expression. And because of that, we need to understand that IBS is a gut-brain connection. You cannot treat one thing without treating the other. Okay? I've been in a room full of people who understand systems approach. I have been a systems person since early in my career where I was in neuro. And we did, from the top to the bottom, everybody did everything. And we looked at that whole person all the time. And one of the things that I was fascinated by was the worst thing that happened, the people who survived the worst things were the ones in the worst trouble. Doesn't make any sense, does it? Mild traumatic brain injuries, they did pretty good. Right? They came out of it, they didn't have terrible GI problems, they had a lot of throat and vocal kinds of stuff. but they didn't have the GI stuff. That the people who had very severe injuries came all the way back. We're walking, we're talking, we're surviving for sure and starting to thrive. Every single one of them had a terrible GI system, whether it was very painful and swelling and distension, or it was severe anismus with constipation. I don't know what the trigger switch is in that, but that's, so people who survive the unsurvivable almost are the ones who end up with that really, really worse presentation. And I think it's just because the sympathetic system has just gotten turned upside down and is in full-blown, no, we're not prioritizing that, we don't care about that. I've just got to keep you breathing. I almost failed at my job, and now I've got to work overtime. So I don't want anyone else around. I don't want you talking to anyone else. I don't want you doing anything else. I want you to just sit right here with me. Right? That's how simple that system is, but that's how controlling it can be. So anyway, in this particular one, they talked about diet, SIBO, constipation, visceral hypersensitivity, and they gave swelling and bloating a new name, abdominal phrenic dyssynergia. All that means is that the muscle system through the trunk is not working in a way that it should. We'll talk about that in a minute. And here's just more things. This is another algorithm, okay? So again, the neuromodulator's low, biofeedback, and the reason that all of these articles, when you look into neurogastroenterology and gastroenterology today and the Journal of Gastroenterology, they all talk about biofeedback therapy. It's because that's all we have published and produced. So you want them to understand more about what we do? We need to get busy and do a little more research so that we have things to hand to them. Rome is doing its job, but we need to be doing our job from the rehab perspective. What do our outcomes look like? What is it that we're doing to achieve those outcomes? Are we even doing the thing as a clinician to just report at a case level? There's a lot of power in that, because when people start seeing case reports coming out, some researcher sitting there going, looking for their next big thing is going, all right, here we go. I wonder what outcome measure we can use with this. I wonder what they're doing. I wonder how they're doing it. Can we match this? Can we do this? So, anyway, old stuff. So this one is kind of a cool one because it looked at everything together and not in an order. But you can see it talks about everything we've been talking about. Gastric and intestinal expansion by swallowed air and CO2, okay? Expanded intestinal fluid, right? So different things that give us stretch to our lumen, which is normal. If our lumen doesn't stretch, it's not going to get the trigger for motility. We know this, right? Because we know people who don't have motility. And they've got a big stretch to it. For whatever reason, their receptors are offline. And that's not a pretty presentation either, unfortunately. I didn't hear that.
I said, would you like to look at it? I got it right here.
Oh, it's uncomfortable, right? Anyway, so we can look at all of these different things, and the list is there for you. But what we're going to talk about today and spend time with is looking at this from this point of view. So we've got thoracic expansion, diaphragmatic descent, and abdominal muscle relaxation. That is the hallmark of the abdominal reshaping because of the visceral somatic responses. All those fancy words. Their belly hurts, their abdominal wall moves away, gets away from the pain, right? Because it hurts if you pull it in against the belly that hurts. So they've got visceral pain, and the abdominal wall just simply moves away. But when the abdominal wall moves away and does that, it doesn't have its pull into the thoracolumbar fascia anymore. So now the back receptors are all saying things like, we're feeling a little loosey-goosey down here, brain. Something needs to tighten up to keep us from sliding all over the place. So the diaphragm comes down in chronic inspir. Familiar with inspir and expir?
No.
Inspir is like the position of inspiration. So if we talk about somebody in inspir, it means their diaphragm, like when we breathe in, our diaphragm comes down, right? It contracts. So the diaphragm tightens up to become a postural control muscle.
Are you serious?
Mm-hmm.
This is crazy.
It is crazy. It It's great. Why do we do stuff like that? It's so bad, right? So these are the things we talked about. You know, there's a lot of things that can happen. So movement system changes, but here's the thing, stomach hypochloridia. So just real quick on this, real quick. I'm going to tell you right now, there's a great book, and I'll show it to you, and you can read all about it. GERD and silent reflux are two completely different things, right? So this is GERD. You can have bloating and diarrhea, acid reflux or heartburn, gas. It comes with SIBO, nausea while swallowing pills and supplements, nutrient deficiencies. Why? Because if we don't have acid in the stomach, we're not absorbing calcium, minerals, and things vital to our bone health. Loss of hair, brittle fingernails. Can't really get into a course with GERD. Happy to come back and do a course on GERD. But here's the thing. This is the stuff that people aren't talking about, and I hear this and see this all the time. What do you do with your clients who are chronically clearing their throat? That's a risk factor for pelvic health dysfunction, pelvic floor changes, right? Well, it's not enough to just think about this. We have to think about, why are they clearing their throat all the time? And who have they seen as a provider? And probably they have already had an endoscopy, but they had it by a GI guy who went down the tube and just decided to look at the cardiac sphincter and the surrounding tissue. We need to refer these people to ENTs because they need to look at the state of the vocal folds and the mucosal membranes of the ears, nose, throats, even eyes. ENT, right? Because what happens is, and this is what goes on in silent reflux, they don't have the GERD, right? They don't have heartburn, like, oh, it hurts, but they do have all of these things. And this is the one that really gets to people. For no reason at all, I just started choking, okay? So this affects the diaphragm and the pressure system, right? So we're going to lead to irritability, bloating, pelvic floor dysfunction. Yes?
Can you have both?
Yeah, 100%.
I've actually just heard about that book and recommended it
Yep.
to my son's GI doctor.
She is the master of the fight, Dr. Kaufman. And she's got a podcast. She's on Facebook. Dropping Acid is on Facebook. She comes on live, I think, about every 2 weeks. She's very passionate about this work. But what she's done is she looks at this. Pepsin's activated in the pH of 2.0. Remember that? What happens is with this is we have a stomach, the cardiac sphincter isn't closing for whatever reason it may be. And usually it's chronic stress. When it doesn't close, the pepsin's getting out of the stomach. And the pepsin is what's coating the sinuses, the vocal folds, the throat, even the bronchioles. How many people who may or may not have asthma, right? Have we really looked at everything? But anyway, they're coating the system, and if we're eating anything lower than a pH of 3.5, it's activating the pepsin. It's causing havoc in our mucosal system. Right? So we got to pay attention to that. And actually, the fix is easy. She outlines it beautifully in her book. Stay above a 3.5. It's hard to do, but you can do it. But the payoffs are almost immediate. Within days, people can start feeling better and start noticing that they're not coughing as much and they're not clearing their throat as much. And a lot of people, especially right now, and we've talked to her about it, is that she thinks that a lot of things that are going on that rightly are being blamed on long COVID, no question about it, but she wonders how much of this has gone offline and how much of this is an issue that if they could just get their alkalinity up in their food and their drink, would that help? And it's an easy single subject design to run on any of your clients. I say give it 2 weeks. Read it, give it 2 weeks. Go all in. See if it makes a difference. Yes?
So then our clients with like high anxiety and kind of that cognitive or psychotropic, like somatic cough, right? That chronic somatic cough from stemming mostly from the anxiety.
Yeah.
So coming at this one, there's that completely different angle versus the mental health side is coming in from ENT, nutrition, diet, to kind of give their brain a new look, a different opportunity.
Or both.
Well, yes, both for sure, but if they've had such a poor experience with the one side for so long. Thanks, Susan. Sorry, I think I'm verbal processing, but this is, like, that would be a
I love it.
typical client.
I love it. I love this crowd. So, okay. So,
Shit. Oh, and then we go into endo.
so I'm not going to talk a lot about endo today. All right, we're just going to stick to the subject going on. But you'll have these slides, and it's all here. It's just that a lot of people with IBS are misdiagnosed endo. That's the take home from going through these slides. Okay, how common is back pain in women with gastrointestinal problems? Again, this study that was done by Paul Hodges and Russell and Maggie Smith, landmark study out of Australia, 38,050 women from 3 age cohorts. This is a super good study. 87%, I don't think I wrote that on there, have both chronic low back pain and GI dysfunction. And this is what they decided was important because they wanted to talk about why that might occur. Referred pain through visceral somatic convergence. All right, that's pain. And so pain in the back is talking to the gut, and so now the gut is acting up too. Right? We can have visceral somatic conversion, we can have visceral convergence, we can have somatic convergence. All the nerves talk to each other through that pathway in the spinal cord.
And this is different from the abdominal reshaping that you were talking about
Same.
earlier? Same
Same. We're just pulling in low back pain with it now.
Alright.
Because you're going to see most of these people have low back pain as well. Altered pain perception, remember the allodemic response to structure of the lumen, increased spinal loading when straining during defecation. Anybody who knows anything about somebody who may have a disc, the question they ask them is, does it hurt when you strain to move your bowels? Right? So, if this is the case though, if we've got somebody with distension and GI and chronic low back pain, and we do have a problem with spinal loading, do you think we should be giving them planks? But that's the number one exercise they give people with chronic low back pain. Which is why I said a lot of this is for me to jump up and down and get my compadres. So like, you've got to pay attention to this stuff. Like maybe planks aren't the thing for them. Or maybe modifications of them if you must. And then reduce support of the abdominal contents and spine secondary to changes in function of the abdominal muscles. So all that fancy stuff. Okay, so what we're going to do here, and I'm just going to put the things down for a minute, we're just going to talk. This article was really cool because Color decided to look at people with chronic low back pain and people who didn't have chronic low back pain. And what he was interested in was the diaphragm. And what they did was they did functional MRIs and they looked at the movement of the diaphragm in people with chronic low back pain and people without. And of course there were differences. The people with chronic low back pain had a higher crust, which means that remember the crust of the diaphragm is where all of the vena cava and aorta and esophagus and all the nerves and everything goes down. And it's very close to the spine. So it pulls up there actually. What happens is the diaphragm descends, but that crust gets pulled back.
Are the crust the attachment points? Is that what you're talking about?
The crust is the circle,
opening.
the opening, yeah.
Okay.
But the diaphragm descends, so it contracts, and then that opening gets pulled backwards. So it has this kind of funny, look like this rather than like, so if the normal diaphragm looks like this, then this one looks kind of like this. Okay?
And you said that was at rest, or as they were inspiration?
No, this is where it was living, and so it was just moving like this. Whereas the people without chronic low back pain, it was doing this. Right? It was going through its full motion, doing it with every breath that it was to do. Then they took them and they decided, let's add some resistance to it and see if that changes anything. So you see the arrows there. What they did, the person was lying on their back. I wish they had done it standing, but they did it lying down. And they just had them press against their hand like this. And on their leg, they had them press up against their hand. So they were just creating an isometric contraction under load. And what they found was both diaphragms did have to work more. So they didn't have as much movement, but obviously the chronic low back pain was way worse. than the movement that was still afforded in people without chronic low back pain, leading them to postulate that the diaphragmatic changes with chronic low back pain is the reason that that it does that is it's got to take over to become a postural control muscle. In chronic low back pain, the extensor muscles are revved up, but the multifidus is inhibited, right? I don't know why that happens. I didn't get to make the design. I just know what we find afterwards. So that sets it up to like make you think a little bit, okay, so if the diaphragm's going to do this in the face of inhibition of multifidus, what's the diaphragm going to do? There's some stuff about the article. What about the abdominal wall and the pelvic floor? What's going to happen here? So they didn't look at the pelvic floor in that one, but in this study they did. And they looked at people with non-specific low back pain with and without. Okay, it wasn't chronic low back pain, but they still did it. They found the same thing in their diaphragm, tidal volume changes with non-specific low back pain versus the regulars. Okay, less diaphragmatic thickness during tidal volume, which means with real-time ultrasound, you're looking for muscles to get fat if they're activated. And so when there's less thickness, that means it's not working as much. Okay? And then, but they also found the pelvic floor had less excursion, okay? And there was a thickness of the external oblique, internal oblique, transverse, and TA at rest. So was it overworking there? Okay, so this was with without the non-specific. So everything worked well. Sorry, I got a little lost in my slide for a second. I'm better when I tell the story. The people without low back pain had really good excursions of their abdominal musculature, their pelvic floor, and their diaphragm. They all worked together in concert. When they had low back pain, actually the pelvic floor had less excursion. And that's the piece we want to kind of get at here, because there's a reason for that. So now we're hooking the picture up together. So now we're going to look at what this actually looks like with a patient. You'll get to see kind of what I've been talking about here. So we're going to compare it to the article of Kohler here. All right, so on this side, what they did in this article is they put gas in people. People that had this type of response, that were complaining of bloating and distension, they put gas inside of them. And then for the people who didn't have that, they put gas in them too. Right? And they wanted to see what the response would be. They were looking basically for the synergistic response to gas loading in the system. And you can see up here, this is normal. The abdominal wall actually comes in the presence of gas. And the diaphragm is free to move. They're not holding their breath. They're not pushing it down. They're not doing anything with this at all. It's just, it's relaxed position. Down here, the abdominal wall moves away from the pain. Okay? At the same time, the diaphragm descends, which is inspiration, it's contracting. And if we compare that with Kohler, it's doing the same thing. That the chronic low back pain, and the same thing they found in the whole real-time ultrasound with non-specific low back pain. And remember, 87% of women at least, they didn't even look at the men, have GI dysfunction, have low back pain. Starting to paint a picture here that makes some sense, right? Because now we have multifidi muscles that aren't working probably, and we have the abdominal wall going offline, thus making it more important than ever for the diaphragm to do what it does. I promise you they fall into the same category posturally that your postpartum clients are in. Because why? We pop the balloon, the abdominal muscles, there's no pain, right? But the abdominal muscles do what? Because they're long now. There's nothing holding them up. Baby was here, we're nice and tight, everything's good. Now baby's gone and we're hanging in. Right? So they're offline, so the brain says, you better do something to hold everything together because you've got to take care of the crying child here. And so the diaphragm descends and becomes a postural control muscle. The pelvic floor either goes offline because it's inhibited from stitches or pain, or it becomes an over recruiter. We don't know. So But that's so you can kind of look at this. The stuff we're going to do today will work with a lot of different things, but I just want you to be able to recognize this dyssynergic pattern, because this is what you're going to be working with here. Okay? So there was one that did a biofeedback thing. You can read the article. It gives you very little details of what they did, but they basically put electrodes on the belly, and they put electrodes on the intercostals. And their job was to get the belly to pull in, to activate, and for the intercostals to deactivate on biofeedback. And they did it with exhalation. Why exhalation? Because that's when the diaphragm rises and relaxes. And that's when the belly naturally comes in. So harness the power of breath to help you build a new synergistic pattern. But in order for us to do anything and get anywhere with our clients, and I know I'm probably speaking to the choir here, but we have to do three things. It needs to be safe, right? It needs to be relevant. They need to understand what they're doing and why we're asking them to work together with us for this. Once we have that, then they will be consistent. But unfortunately, what I see in a lot of rehab science is expecting the consistency without really giving the time and space to the relevancy and to the safety. So, with that said, we're going to work with this client in a way that's going to be a little bit better. It's going to help achieve safety, help achieve relevance, and help achieve consistency. What I do with my clients who are in this kind of presentation is I ask them to come to me when they are not good. I don't want to see them in the morning. I don't want to see them in the middle of the day, but I want to see them when they're not good. Because that's when they're going to find the relevance of what we do. Because I can teach them, I can teach anybody to do this. But when they go home and they hurt and they panic, they're not doing it. Did you do the thing I told you, I asked you to do when you hurt? Forgot all about it. I couldn't even think. I was just like right back in my same place that I was in. So see them as bringing into relevancy. The same thing with chronic constipation, teaching all of this lovely synergy work to get people back into synergy and have this nice, open, relaxing EAS when they poop and they get it, they come to you, they work with you, we get it going, and then they stool drops in at home, and what happens? They go right back to their synergistic response. And the reason that happens is because we're not working with them under load. That explains why they look so good with you, but yet they still can't poop. So this isn't a balloon catheter, of course, but this is exactly where the balloon catheter comes in. It's the only way we can introduce a load into the rectum. And if you have clients like this that look really great, but they still can't poop, put that load in and watch that dyssynergic response show up like that. Right? Because we're working with them now under load. Now you have a chance to make the changes. And now they'll see the relevance of why we're breathing this way, and why we're putting our feet up, and all of these things, because they're going to be able to learn to move that load through. So what we're going to do here is we're going to do a little bit of just kind of like that. We're good. We're good. Okay. We're good. So let me just tell you this. In your bags, you've got a card that has my face on it and a QR code. There's a video on this. I'm not going to show the video here because we're going to do it in real time. But there's a video. You won't get the slide show, so you won't get the video. But I'm giving you the video as a gift. Okay? So all you have to do is you've got to click that QR code though to get it. So that means you have to give me your email address. Sorry about that, but that's the way the game is played. Anyway, you'll have the video to watch. Because you'll go away and you'll think you remember all of this, and next week you won't. I know how that works. So anyway, I'd like to get a volunteer, if I could. I saw your hand first.
You're describing me, and I'm putting all the pieces together, so I feel like.
Good.
Susan, can I put the lapel on you quick? I just found out that it's not recording your voice because I don't have the mic. That's why I have my phone pointing right there, because it's been recording the whole first half.
I'm sorry.
I know, I got,
Stop here.
well, I know, but I got the whole first half on my phone.
Okay.
So, and we're just
Good.
gonna have 2 videos for your part for the recording after.
Okay, you can call it this stuff and then you can call it lab perhaps. No problem. Okay, we need to make this higher. Who's the table person? Somebody, oh, you're a table person, good. Okay. A little bit higher. Good. And you're gonna go down to the end and stand there. And I'm gonna talk for a second. All right, so the idea here, you can get people in quadruped, but I have a lot of people who aren't gonna get on their hands and knees on the floor in the office, or they can't get on their hands and knees. So I teach people to do this kind of in a forward bent position. So let's say that she's not feeling good and she's got the distension part of everything going on. So what we're gonna do is I'm gonna have you put your forearms on the table and you're gonna lean just like this, okay? Please only use them for your own thing. All right, so I'm trying to figure out how to do this, and you don't mind if my friend's there with you, do you? Okay, let me come on the other side. Just scooch over to the left just a little bit. Ah, thank you. Yes, I forgot I have jeans on. It works. Perfect. Even though I couldn't find my belt this morning. Oops, let's lock that. All right, technical difficulty solved. Microphone's on. Table's locked. All right, all I want you to do, I want you to be comfortable. Are you comfortable? You can bring your feet a little wider apart if you want to, and let your knees just kind of bend. There we go. I'm gonna put my hand right here, and all I want you to do here is just let your belly go. So let it drop into my hand.
Really tight, so I'm gonna.
That's up to you, my dear.
Undo that.
Okay.
I did during yoga, I don't care.
Okay, I don't care. I'm not the one bent over the table. All right, so just let it drop. And you want to stay with them here because what I don't want them to do is arch, right? To drop their belly down, nor do I want them to blow their belly out. So you just kind of like hang there. If your hand is here, they're going to let their belly go. In our culture, if we don't give them a reason to do it, they're not going to do it. Okay, there we go. I'm trying to get her long and away from her pain. Good. And just breathe easy there. Just easy breathing, easy breathing. I'm going to come up to her thorax. I'm just going to give her a little assistance with her breathing. And I'm just giving a little pressure in to hold her ribs down so her diaphragm can let go and exhale. That's what we're doing there. The other things you can do, are you okay? Do you need a break? Okay. The other thing you can do is, and we'll come around and help you with this part of the lab, is you can just kind of come in here and do whatever soft tissue work you love to do. I'm just looking and working with the obliques here, side to side, just getting everything to kind of like let go and be, get in the flow, right? And then you can come up here and you can work with the ribs and you can help them, you can move them, whatever your jam is, right? Whatever works. And then I'm just gonna have you take a breath in and a breath out, blow through your mouth nice and easy, and just help her with her exhale, just like we've got that going. So now we've got the belly relaxed, we've got the exhale going. All you're gonna do with your belly now is just slightly lift it towards your backbone. Real easy. And then let it go. Does that hurt? Okay. And so you would ask, right? Does that hurt? Because we don't want to make them hurt. Lift and let it go. Good. Lift. Blow the air out. Inhale and let your belly go. Good. Exhale and lift your belly. Inhale and let your belly go. Beautiful. Now, final thing. Lift and hold right here. Keep it here and breathe in and out for me. Keep your belly right where it is. Breathe in and out with breath. You can see she's forcing now She's having to use her diaphragm. Good. Perfect. Let everything go and go ahead and stand up.
It's uncomfortable, that change.
Yeah.
That's not normal.
No. Because you've been breathing a different way with it for a while.
Yeah.
We're going to sit next, okay? So if you want to leave your pants open,
Sure.
whatever you want to do. Why do I have her hold her belly in slightly and then add the breath on top of it? Because if you think about squeezing a bottle, right, running it through, we can speed up how fast it comes out by squeezing the bottle, right? They need to expel gas or move things through their system. So by contracting and using the muscle pump of the diaphragm, we're just doing basic plumbing, right? We're gently helping them establish a muscle pump, and we're creating a riverbed for the lake to begin to move through. So if you need a different type of thing for somebody, I like a squeeze bottle because I'll just show it to them. But some people respond to other things. You know, the lake, as it goes to a river, the riverbed, it comes closer in, and what does the water do? It goes faster, and more of it gets in there, right? But it has to go faster every time. So if we want to change this, we've got to develop the canister, and then we've got to do the squeezing on top. For your people who are having trouble with chronic constipation, this can be a game changer. This goes, you know, nobody's really considered this type of maneuver with that, but it can really help people because they have something that they can actually do. And when they start adding that breath in, it really all of a sudden, they start feeling things that they weren't feeling before. Again, consistency. They have to do it every single time. They sit on the toilet to have a bowel movement, but eventually they'll get that synergy down and be able to do it. And sitting, we're going to do the same thing, only you get to put your hands on your belly. Yeah, just right here, where you're comfortable. Okay. Good. And let your belly go. And then I'm just going to make sure she's stacked, right? And she's not going to be sitting in kind of that sway back posture or something like that. We're going to get them nice and stacked. Let the belly go. It's almost like you're holding a ball. You present the ball, and you bring the ball back in. So bring the ball in by bringing your belly to your backbone. Good. And out. Don't worry about your breath right now. Just do this movement first.
Just do the movement.
Just do the movement first. There you go. One more time. Just play with it. Does it hurt? If it hurts, don't squeeze in so much. Only go where you feel good. Good. Now you can add the breath to it. So breathe out. There you go. And in. Nice and easy. And out. So we're just coordinating again. And then now you're just going to bring that in and just right where it doesn't hurt, but keep it there. And breathe in and out. Think of your diaphragm doing this. Or an umbrella opening and closing. And you can see she's starting to use more of this area. So it's not being held as stiff and as tight as it was. And then we can do that standing up against the wall. Okay? I just have them if you want to. You can come stand right over here. Sure. Is it easier sitting up or bending over? Bring your feet up from the wall. So my question was to her, is it easier sitting up or leaning forward? I always want to know, because everybody, I think it probably should be easier that way, but I've had people say, oh, I really like the sitting one, or I really like the standing. Mm-hmm.
I feel like yeah.
Yeah, so that's your go-to. Okay, back against the wall. Walk your feet out a little bit. There you go, but your back stays on the wall. Hip stays on the wall. There you go, walk your feet out a little bit. There we go. Bend the knees slightly. Good. Now, do your thing.
Oh,
do your thing.
Here.
Stay in here. Put them against the wall because it gives them a little stability. Eventually, they get where they can do it without having to be, they can just, in the middle of the room, do it. So but we want to give them safety. It's irrelevant because I'm seeing her when she's in pain, and we're working on letting her only work, because you saw that when she was sitting there, she was going, oh, it hurts a little bit. It's like, don't go so far. We're right there with them in the moment. so they can see the relevancy and the variance of how this can work. And then they can be more consistent because we're giving her 3 different positions. And one of them is one that she's likely going to do, like be a go-to. How does it feel? Thank you. Okay, we're going to break apart to go do this in the lab in just a second. Yes, we'll start here.
Do you recommend taking them to a toilet and have them practice that same thing?
Absolutely. Yeah, we do, and with the balloon in and everything. Like, it's a strategy that I use for a lot of different stuff. So, but yes, 100%. Make it real. That's the whole thing about, what was it? Robin Murray I was talking to her this morning, and she goes, I really want a GI course. And she goes, people are just so shy about the back of the house. It's like, I am so stealing that. So let's get people out of the back of the house. Let's get it out in front and do it. Go ahead.
So one of the, I use this for tons of different things, but one of the things is like blocking off your stomach with a pillow and like breathing into your back, whether they're in a child's pose or just leaning in a chair. I find that it has helped my clients with constipation, but I never have to like contract the abdominals. With that, obviously it probably
You could do that. The only reason I wouldn't do that position in the face of this is because pressure on their abdomen is painful.
Right, yeah.
Right, so the people who are not having the pain, it's definitely, yeah, and you can have them just hold that. They've got the pillow could be the trigger for them to kind of like pull in gently and do the breath, and breathing through the back, breathing into your lungs, breathing into water balloons, whatever you want to use visually, that gets it for them. It's great. Yeah, 100%. Teresa.
Yeah, so when you had her leaning over on the table, it seemed like you did, where you had her relax her abdominal wall and keep it relaxed, but inhale, exhale while the abdominal wall stayed relaxed. And then I didn't see you do that in sitting and standing.
Because of the length of time. You can do all of that. The goal is to be able to get the diaphragm moving, and then be able to get be able to tolerate that abdominal wall coming in enough to give them the squeeze bottle.
I thought you said to have her belly in, she would like hold her belly in.
Right, but in the beginning, we just had her get relaxed and stay relaxed because that meant the belly swelling pain was better. Now just breathe. Like, let's just enjoy the moment for a minute. And then I coordinated. Then I had her work on lifting her belly, and then we lifted the belly with exhale, right? And then we lifted the belly and held it, and then did the breathing on top of it. So this didn't move at that point. It stayed there where it was comfortable, and you don't need much. This is not an abdominal hollowing type maneuver at all. And that's why I want to see them when they don't feel good, because that's when I can make sure that they're only tightening up. That's not making their pain worse. If I teach them this and they go home and they try it, they're going to overwork their tummy and they're going to hurt and they're going to say, that didn't work. Right? So that's why I want them to come in when they don't feel good, when they're distended. Yes?
I have 2 questions. One is around the abdominal contraction. Do you teach like an actual TA like contraction before you do that, or like you're just giving a simple cue belly to back thumb? Yeah, okay. So you're not like overthinking.
I'm not interested in any of that. I'm interested in that abdominal wall coming in slightly because that's the piece of the synergy they're missing. Right? It's not specific to one muscle or another muscle. You can divide them out, but this works. Okay. Yeah, just thinking about, keep it very simple.
And then my other question was, so I do some of what you're talking about, but in a different position, and I found that some people have a really hard time with that interoception of like relaxing their abdomen. And I'm curious, like if your hand there, obviously, like that's feedback. So I'm curious, like how you support them when that interoception is really hard for them to feel.
We just meet them where they are and work with what they'll do.
You'll never use like you'll never use like props or anything like that.
You could. I've really never really needed to do much. I just meet them where they are. And most everybody can get it. It may take a time or two. It's just more willing for them to like let go. I find it's much more of a willingness because we're so accustomed to like hold it in, right? So getting them safe, you know, that's why in the clinic with the door closed, comfortable, you know, and where would they do this? Because they're not likely to lean over their desk at work probably and do it, which is why I do several different things. A lot of go-tos are, when you go to the bathroom, just sit there and do this, right? Or close the stall door, put your back on it, or on the side of the stall and stand there and, you know, 1,440 minutes a day, in a day, you've got 2 minutes to do this.
Building on your perspective, I have had people like videotape themselves on their own phone a couple times, like if they can't feel it and they wanna have their arms down and just like, if you're at the house, like roll your shirt up and tape yourself and just see like where you're getting to. And so sometimes just having that visual feedback can help.
So, and another way that might work is sitting and put your knees wide apart and lean forward over to something, and that may feel a little bit more safe to them. So you can play with this. These are just guidelines. Do you see Captain Jack Sparrow? Right? They're just guidelines. Yes?
So from a guide perspective, a lot of the times we work a lot on diaphragm breathing.
Uh-huh.
My question is, I noticed that people who are CPAP users are the most difficult people to understand and train in diaphragm breathing. And I'm wondering if you see that same correlation or
Can we save this question for the end? Yeah, because that's going to take us along a whole nother route, which I'm happy to do, but I want to get through what we have to get through. All right. Are we good so far? All right, we're going to do this. So there we go. And then we're going to do something with the neural tension piece. Okay, so what I want you all to do is I want you to find a place to lean over, get a partner. I'm going to give you 5 minutes per person to do this. Just go through it, okay? Okay. Everybody, let me get everybody's attention. The goal of these few minutes is to just do the movements to get them in your head. We don't have time to spend a lot of time with this. I wish we did, but we don't. But that's why you're getting the video, so that you can look at it, you can practice, you can play, and do all of those different things. Okay? So let's make this happen.
What was the cue you gave her to like allow her to soften
Just,
your hand?
yeah, just go ahead and get down. All I'm doing, let your knees bend slightly. There you go. Wherever you're comfortable. Just let your belly drop into my hand. There you go. Don't blow it out. Just let it drop. Let it drop. Let it drop. Good. Yeah. So Melissa and Lynn are walking around the room. You all know Lynn and you know Melissa. So they're here to help. So wave your hand if you want some feedback or something. All three of us are here.
Giving a little bit of compression.
With exhale.
With exhale. With exhale.
Looks good. You guys okay? Good. We okay? Uh-huh. I'm sorry? Uh-huh. So you've got her relaxed, right? Yeah. Nice relaxed belly. Good. And then as she exhales, she's going to, so have her work on bringing her belly in and letting it go, right? And then coordinate that with breathing. So with exhale, she does this.
Okay.
And inhale, she does this, right? And then the final thing is bring it up and hold it and have her breathe in and out, not moving this.
Okay.
Okay?
Got it.
Good.
Thank you.
You're welcome.
I find a lot with my clients that like the gravity like fights against them, you know?
But this is just a lovely way to get that to be long.
Yeah. Because I mean, like you said, like society is like,
Yeah.
you know,
Right. It does. It does. Yeah. Yeah. So I kind of like will take you and just say, look, somewhere in the middle is the truth. We don't have to lean down. We don't have to press up. And oftentimes I'll just put my hand right here just to say, come on, let it go. Let's go.
yeah,
Okay, if you haven't switched, switch. If you haven't switched people, please switch.
yeah. That's awesome. Really awesome. That felt really good. All in the pipe.
There. Ooh, that was good.
Kelsey, we are running out of time, so I'm going to end it, and then I'm going to promise them, I've got this next part on a video.
Okay.
I'm going to send it to you to share with them, because we didn't get to the neuroregulation part, and I know that a lot of them wanted that. So I've got this recorded. It's not a big deal, so I can just have my person cut and paste it and ship it off to you. Do you mind putting it into the thing for everybody?
100%. I'm going to add it to my notes.
Yeah, and please remind me,
Yes.
because I'm going to be out of town for a week, and I'm happy. And I want to be sure that I get that, because I can get that done this week if you'll remind me.
Okay.
It's easy for me to do. Yeah, super easy for me to do. Okay, unfortunately, we need to get back together so we can, you're welcome. Let's get everybody back together quickly because we're supposed to be done in 3 minutes.
Compression, like, as she was exhaling, almost like a minute down.
Okay, so much to cover, so little time. Here is my gift to you, because we didn't get to the neural tension piece, and we did not get to the to the vagus regulation pot, which is really, really important, because again, we've got to treat the central nervous system as we treat the musculoskeletal system. So I have this already in a video, the rest of this. I'm going to get my VA to clip it, and I'm going to give it to Kelsey to post with all of the stuff that comes from this. So you'll have the slides, you'll have the video from the extra video, and then if you click on my QR code, you'll get the video of this maneuver. Is that good? Okay. And hopefully I will be back sometime and we can do whatever you want to do. Thank you, everybody. Thank you. I want bubbles.
And Susan's so fantastic that if there's something specific you want to hear from her in the future, let us know.
Yes, please. Like, I know that everybody was thinking about a lot of things, so I'm happy to return and talk about what's... Thank you. This is awesome. All right.
Can we do one more bubble blow so I can get it, like a picture so I can send it to Susan? Sorry, I hope you're okay with that.
I'm fine.
Okay, we should have something good.
Awesome. Thank you. Thank you, everybody. You're welcome. Okay, so if you want to get in touch with me, the QR code will have my get in touch information. I'm on Instagram as @sclintonpt, so you can always DM me there. Let me know what you need.
Shameless plug for your
Hmm?
podcast.